I need to tell you something that took me a long time to say out loud in a public setting like this. Not because the information is complicated, it is actually straightforward once you understand the biology. And not because the research is unclear. The research on this has been building for years and is genuinely consistent. The reason it took me time is that what I am about to share directly contradicts the advice that millions of older adults are following right now. Advice they received from their doctors, from their pharmacists, from the labels on the bottles sitting in their medicine cabinets. And telling people that something they have been doing for years with the sincere intention of protecting their health may actually be working against them is not a comfortable conversation to start. But it is a necessary one. Here is the core of what I want to tell you today. Several of the most commonly purchased supplements among adults over 70 interact with each other and with common medications in ways that create real biological problems, not theoretical problems, not rare adverse events that only affect a fraction of a percent of users. Documented, measurable, clinically significant interactions that affect a substantial portion of the people taking these combinations right now without knowing it. The supplement industry has known about most of these interactions for years. The information exists in the research literature. It is simply never communicated at the point of sale because supplements are not regulated the way medications are, and nobody is legally required to tell you that the 3 bottles you just put in your cart should not be taken together. My name is Dr. William Madison. I have been in clinical practice for more than 20 years, and I want to spend the next several minutes walking you through 3 specific supplement combinations that I consider the most important for adults over 70 to understand. I will explain the biology of why each combination is problematic, what symptoms it can produce that are often misattributed to aging or other causes, and what to do instead. Before I go any further, I want to be clear about something. I am not telling you to stop taking supplements. I am not saying supplements are dangerous across the board. Many of the individual supplements I am going to mention have genuine, well-supported health benefits. The issue is not the supplements themselves. The issue is specific combinations, specific timing, and specific interactions with medications that change how these substances behave in the body. Please do not make any changes to your supplement or medication routine based on this video alone. Use this information to have an informed, specific conversation with your doctor or pharmacist. That conversation is the action I am asking you to take. With that said, let us talk about what is actually happening in the bodies of millions of older Americans every morning when they open their supplement cabinet. The first combination I need to talk about is calcium taken together with magnesium, particularly when both are taken at the same time in high doses. This is probably the most widespread supplement combination among adults over 70 in the United States. Calcium is recommended for bone health. Magnesium is recommended for sleep, muscle function, nerve health, and cardiovascular support. Both recommendations are backed by real research. Both nutrients are genuinely important for aging bodies. And in millions of households, both are taken together at the same time, often in a combined product specifically marketed as a calcium-magnesium supplement. Here's the problem that the combined product packaging does not explain. Calcium and magnesium compete for absorption in your small intestine. They use the same transport channels to move from your digestive system into your bloodstream. When you take them together in significant amounts, they essentially fight each other for access to those channels. The result is that you absorb less of both than you would if you took them separately. But the consequences are not symmetrical. Most older adults are consuming substantially more calcium than magnesium in their daily diet, even before supplementation. Dairy products, fortified foods, and many common foods are high in calcium. Magnesium, by contrast, is found primarily in foods that most older adults eat in smaller quantities, including dark leafy greens, nuts, seeds, and legumes. By the time the average adult over 70 opens a calcium supplement, they are starting from a position of calcium abundance and magnesium deficit. When you then take a high-dose calcium supplement alongside magnesium, the calcium wins the absorption competition because it is already at higher levels in the body and because the body prioritizes it. The magnesium that you thought you were supplementing passes largely unused. This matters significantly because magnesium deficiency after 70 has consequences that are widely misattributed to aging itself. Muscle cramps, particularly the nighttime leg cramps that wake people from sleep, are among the most common symptoms of magnesium insufficiency. Poor sleep quality, specifically difficulty staying in deep sleep, is closely connected to inadequate magnesium levels. Heart rhythm irregularities, constipation, anxiety, and elevated blood pressure have all been associated in research with chronic low magnesium status. So here's what happens in practice. An older adult develops nighttime leg cramps. They mention this to their doctor. The doctor, correctly, suggests magnesium supplementation. The patient goes to the pharmacy, buys a calcium-magnesium combined supplement because it seems efficient to address both at once, and continues taking the same amount of calcium they were already taking. The magnesium is largely blocked from absorbing by the high calcium load. The leg cramps continue. The patient concludes that magnesium supplements did not work for them. The underlying magnesium deficit is never actually addressed. I have seen this exact sequence play out more times than I can count. There is an additional layer to this problem that most people are never told. Excess supplemental calcium, meaning calcium taken well beyond what the body actually needs, has been associated in research with arterial calcification. The Rotterdam study, which followed thousands of participants for years, found that high supplemental calcium intake without adequate vitamin K2 was associated with increased calcium deposits in arterial walls. This is the same calcification process that stiffens blood vessels and reduces circulation, including to the heart. The heart needs magnesium to regulate its electrical rhythm properly. The arteries need K2 to prevent calcium from depositing in their walls. When calcium is taken in excess without K2, and when it simultaneously blocks magnesium absorption, you are creating a situation where your heart muscle is undersupplied with the mineral it needs for rhythm regulation, while calcium deposits in the vessels supplying it. This is a combination of events that the individual components of the supplement cabinet taken in isolation would not suggest. Here is what to do instead. Take calcium and magnesium at least 2 hours apart. Most people find it practical to take calcium with breakfast and magnesium at bedtime, which also capitalizes on magnesium's natural sleep-supporting effect. Reduce supplemental calcium to the amount genuinely needed to reach the recommended daily intake, factoring in what you are already getting from food. For most adults over 70, 400 to 500 milligrams of supplemental calcium is adequate when dietary sources are included. 1,200 milligrams of supplemental calcium, taken on top of a calcium-adequate diet, is where the problems begin. And take vitamin K2 in the MK7 form alongside your calcium to direct that calcium into bone rather than into arterial walls. The second combination that I consider critically important to address is fish oil taken together with vitamin E, particularly when either is taken alongside blood-thinning medications. Let me explain why this combination deserves serious attention. Fish oil, specifically the omega-3 fatty acids EPA and DHA, has a mild blood-thinning effect. It reduces the tendency of platelets, the small blood cells responsible for clot formation, to clump together. This effect is one of the reasons fish oil is associated with cardiovascular benefit. In moderate amounts, this mild anticoagulant effect is protective. Vitamin E, specifically alpha-tocopherol taken in higher doses, also has a blood-thinning effect. It inhibits platelet aggregation through a different mechanism than fish oil, but the outcome at the level of your blood's clotting capacity is the same direction: less clotting tendency. When you combine fish oil and high-dose vitamin E, the blood-thinning effects add together. You are now affecting platelet function through two separate mechanisms simultaneously. For a healthy adult not on any medications, this combined effect may still fall within a safe range. But for an adult over 70 who is also taking a daily aspirin, which has its own platelet-inhibiting effect, or warfarin, or any of the newer anticoagulant medications like rivaroxaban, apixaban, or dabigatran, you have now stacked 3 or more separate blood-thinning influences on top of each other. The result is a level of anticoagulation that can become clinically significant without anyone realizing it is happening, because the supplements were not prescribed and are not being monitored the way the medication is. Here's what this looks like in real life. Bruising more easily than expected. Cuts that take noticeably longer to stop bleeding. Nosebleeds that occur without obvious provocation or that are difficult to stop. In more serious cases, gastrointestinal bleeding that presents as black or tarry stools or as blood in the stool or urine. These are symptoms that are regularly attributed in older adults to the blood-thinning medication they are taking, with the dose adjusted accordingly, without anyone asking whether supplements are adding to the effect. If you are taking a prescribed anticoagulant and you are also taking fish oil and high-dose vitamin E, your actual level of anticoagulation is likely different from what your doctor thinks it is based on your prescription dose alone. There is a specific issue with vitamin E dosing that I want to address directly. The research on vitamin E and cardiovascular health used doses in the range of 400 to 800 international units daily. Many of the supplements on pharmacy shelves are in this range. At 400 international units, vitamin E has measurable platelet-inhibiting effects. At 800 international units, those effects are more pronounced. This is not a concern for someone taking vitamin E alone with no other anticoagulant influences. It becomes a concern when it is layered on top of fish oil and aspirin or prescription blood thinners. The research on this is not subtle. A meta-analysis examining vitamin E supplementation at doses above 400 international units found a small but statistically significant increase in all-cause mortality in older adults, driven primarily by cardiovascular and hemorrhagic events. The investigators concluded that high-dose vitamin E supplementation should be used with caution, particularly in individuals with cardiovascular risk factors or on anticoagulant therapy. For the record, lower doses of vitamin E, in the range of 100 to 200 international units from mixed tocopherols, do not carry the same concern. The problem is specifically with the high-dose, single-form supplements that dominate the pharmacy shelves. Here's what to do instead. If you are on any anticoagulant medication, including daily aspirin, have a direct conversation with your doctor about whether fish oil supplementation is appropriate for you, and, if so, at what dose. The research-backed cardiovascular benefits of omega-3 fatty acids can often be achieved at 1 to 2 grams daily, which has a more modest anticoagulant effect than the 3 to 4 gram doses some people take. Keep vitamin E in the lower range from mixed tocopherol sources rather than high-dose alpha tocopherol. And if you are bruising easily or noticing prolonged bleeding from minor cuts, mention your supplement use explicitly to your doctor. The supplements you are taking are directly relevant to understanding that symptom. The third combination is the one that I consider the most underappreciated and the most important for adults over 70 to understand, because it involves something that almost nobody is monitoring. It is the combination of calcium supplements, zinc supplements, and iron supplements, or high-iron foods, taken together, and what they collectively do to your copper status. I want to explain this carefully because it is less intuitive than the previous two, but the consequences of missing it are significant. Your body requires copper for a range of critical functions. Copper is essential for the production of collagen, the structural protein that maintains the integrity of your blood vessel walls, your connective tissue, and your joint cartilage. It is required for the proper function of an enzyme called ceruloplasmin that is central to iron metabolism and the prevention of oxidative damage. It is involved in myelin production, the protective coating around nerve fibers, and it plays a role in the synthesis of dopamine and norepinephrine, neurotransmitters involved in motivation, focus, mood, and the regulation of blood pressure. When copper is deficient, these functions are impaired. Blood vessel walls lose structural integrity. Iron accumulates in tissues because it cannot be properly processed without adequate ceruloplasmin. Neurological symptoms develop, including the kind of peripheral neuropathy, numbness, tingling, and balance problems that are virtually indistinguishable from B12 deficiency neuropathy. In fact, copper deficiency neuropathy is one of the most commonly missed diagnoses in older adults presenting with neurological symptoms, precisely because B12 deficiency is checked first and sometimes found, leading the investigation to stop before copper is ever measured. Now here is the interaction that matters. Zinc and copper compete for absorption in the intestine through the same transport proteins. This interaction is so well established that high-dose zinc supplementation is actually used therapeutically in certain copper overload conditions, specifically because it blocks copper absorption. When you take zinc supplements regularly, particularly at doses of 50 milligrams or more, you are meaningfully suppressing copper absorption. At doses of 100 milligrams or more, which some older adults take for immune support or based on recommendations from wellness sources, the copper blocking effect is substantial. Calcium also reduces copper absorption through a separate mechanism involving the intestinal environment. When calcium is present in large amounts in the digestive system, it creates conditions that reduce the solubility and therefore the absorbability of copper. This effect is less dramatic than the zinc-copper competition, but it is additive. Taking high-dose calcium at the same time as zinc, at the same time as consuming iron-rich foods or iron supplements, creates a digestive environment where copper absorption is suppressed from multiple directions simultaneously. The result over months and years of this combination is a gradual, progressive copper deficit that develops silently because nobody is testing for it. Standard blood panels do not include copper. The symptoms develop slowly enough that they are attributed to aging, and the person taking the supplements is doing so with the genuine intention of supporting their health, unaware that the combination they have assembled is depleting a nutrient their nervous system depends on. Let me describe what copper deficiency looks like clinically, because I want you to be able to recognize whether any of this matches your own experience. The neurological symptoms of copper deficiency are the most serious and the most commonly missed. They include progressive weakness in the legs, particularly difficulty with stairs or with standing up from a seated position. Balance problems that worsen gradually over time. Numbness and tingling in the feet and hands. A gait that becomes increasingly unsteady. These are the exact symptoms that most older adults and most physicians attribute without question to aging, to B12 deficiency, or to peripheral vascular disease. Copper deficiency is rarely in the differential diagnosis, unless someone specifically asks for it. The cardiovascular symptoms include increased bruising, because copper is required for the cross-linking of collagen in blood vessel walls. Poor wound healing, and in some cases, anemia that does not respond to iron supplementation, because copper is required for the body to incorporate iron into red blood cells properly. This is a particularly frustrating presentation for patients who are taking iron supplements, seeing no improvement in their iron levels, having their iron dose increased, and never being told that the real problem is that they cannot use the iron they are getting because copper is inadequate. The immune symptoms include a gradual reduction in immune competence that is again attributed to aging rather than to a correctable nutritional deficit. Here is what to do about this. Ask your doctor to check your serum copper and ceruloplasmin levels. These are not included in standard panels, but they are routine tests available at any laboratory. If you have been taking 50 milligrams or more of zinc daily for more than a few months, your copper levels should be checked regardless of whether you have symptoms, because the depletion can precede symptoms by months. Separate your zinc and copper supplementation by at least 2 hours if you are taking both. 1 to 3 milligrams of copper daily is the generally recommended maintenance amount for adults taking zinc regularly, though specific needs vary. Reduce zinc supplementation to the lowest dose that meets your actual need. For most adults over 70 who are not dealing with a specific zinc-dependent condition, 8 to 11 milligrams daily from diet and supplementation combined is adequate. The high-dose zinc supplements of 50 to 100 milligrams that are marketed for immune support are appropriate only for short-term use during acute illness, not as ongoing daily supplements. Take your zinc and calcium at different times rather than simultaneously, both to improve zinc absorption and to reduce the combined impact on copper status. The copper-containing foods worth incorporating into your diet include shellfish, particularly oysters, which are extraordinarily rich in copper, beef liver, dark chocolate, nuts, particularly cashews and almonds, and seeds, particularly sunflower and pumpkin seeds. These food sources of copper are less affected by the supplement interactions I described because food form copper is bound to different compounds than supplemental copper and is absorbed through slightly different mechanisms. Let me bring these 3 combinations together now, because I want you to see the larger pattern. The problem is not that supplements are harmful. The problem is that the supplement industry sells individual products with individual health claims, and nobody in that transaction is responsible for telling you how those products interact with each other or with your medications. The bottles sit next to each other on the shelf. The marketing for each one is compelling. You assemble a supplement routine based on individual recommendations from multiple sources, none of which considered what the others were recommending. And you end up with a combination that was never evaluated as a whole. Your body does not evaluate supplements individually. It receives everything you put into it simultaneously and has to manage all of it through shared transport systems, shared metabolic pathways, and a single cardiovascular and nervous system that has to deal with the combined effect of all of it. This is why the supplement conversation your doctor should be having with you at every annual visit is not just about medications. It is about everything you are taking. Every vitamin, every mineral, every herbal product, every protein powder, the complete list. And if your doctor has not asked you that question in detail recently, I want to give you the framework to bring it to them yourself. Write down everything you take, every supplement, every dose, every time of day you take it. Include your medications. Bring that list to your next appointment and ask specifically, given my medications and my health history, are there any interactions or timing issues I should know about with the things on this list? That question, asked with a complete and accurate list in hand, is the most valuable thing you can do with the information in this video. The 3 combinations I have described today are the most common and the most consequential that I see in older adults. But they are not the only ones. A comprehensive supplement review is not a one-time conversation. It is something worth revisiting every year as your medications change, as your health needs change, and as new research accumulates. I want to close with something that I think is important for the way you carry this information forward. The fact that these interactions exist does not mean you have been doing something reckless. It means you have been trying to take care of your health with the information available to you, in an environment where the people selling you these products are not required to give you the complete picture. That is a systemic problem, not a personal failure. The response to that reality is not fear or frustration. It is a better conversation with your doctor, a more complete list, and a more informed approach to what you take, when you take it, and why. If this gave you something useful today, please share it specifically with someone in your life who is over 70 and manages their own supplement routine. Not as a general share, but as a specific message to that specific person, because you thought of them while reading this, and you want them to have this information before a symptom develops that nobody correctly attributes to a supplement interaction. The gap between what the research shows and what reaches the people who need it is where a lot of preventable harm lives. Closing that gap, one conversation at a time, is exactly what this is for. I'm Dr. William Madison. Take care of yourself, take care of the people around you, and I will see you in the next video.